Now, the patient of a tubal ectopic pregnancy has a wide range of patterns of presentation. So, the ruptured tubal pregnancy with intraperitoneal hemorrhage has a characteristic triad of symptoms, that is, amenorrhea, abdominal pain, and vaginal bleeding. So, any patient that comes to you with a ruptured tubal pregnancy will have these three symptoms, as you have already seen in that scenario which I discussed in before the start of the topic. Then I have written this scenario here, and this is to help you understand and grasp a stronger concept of how the patient presents to you. The scenario is asked in 2018, 2015, and 2011. A 28 years old lady presented with history of amenorrhea for last 2 weeks, severe pain in lower abdomen. See amenorrhea, abdominal pain, and shoulder tip. Shoulder tip pain is also a very common symptom seen in ectopic pregnancy. Her on general physical examination BP is 80/40, BP is low, pulse is high. On bimanual examination, cervical excitation is positive, meaning she is having cervical pain, and her pregnancy test is also positive. So this is a confirmed diagnosis that the patient has presented with a ruptured tubal pregnancy. And moving on, amenorrhea. Amenorrhea, at the time of presentation, amenorrhea is present in 70 to 85% of patients with 6 to 8 weeks duration. Then the patient complains of abdominal and pelvic pain. In 95% of the cases, the pain is colicky in nature and initially restricted to the affected side, but as the time passes, it later on spreads to the contralateral side and even to the whole abdomen. Why is this pain caused? This pain is caused by stretching of serosal layer of hematoma or by escape of blood into the peritoneal cavity, causing abdominal pain. Moving on, vaginal bleeding. The patient presents with vaginal bleeding in 75 to 80% of the cases, and it is small in amount and dark in color. Rarely it is heavy enough to mimic normal menstrual cycle, and this bleeding is mainly uterine in origin and results from the breakdown of decuda after the pregnancy dies. Okay, if you should know that in what is the relationship between ectopic pregnancy and vaginal bleeding. So this is due to the breakdown of decuda after the pregnancy dies and the hormones are withdrawn. Bleeding may partly be contributed by the ruptured fallopian tube. Then the patient may go into shock. Shock is associated with ruptured tubal pregnancy is frequently associated with massive intraperitoneal hemorrhage, and the patient is often brought to hospital in a state of shock. Then there are some other subjective symptoms of pregnancy. General symptoms like breast tenderness, nausea, and urine frequency are seen in 50 to 75% of the patient, meaning that the patient may say that she has pregnancy like symptoms. And then shoulder pain. Free blood in the peritoneal cavity can irritate the diaphragm, which causes a referred pain in shoulder tip. So the shoulder pain, if you think about it, if you have not studied the topic deeply, so you may think about it that what is the relationship between shoulder tip pain and ectopic pregnancy. So the reason is that the free blood in the peritoneal cavity irritates the diaphragm, which causes referred pain in the shoulder tip. What do we see on general physical examination? The patient has tachycardia and hypotension with ruptured ectopic pregnancy, and if there is massive intraperitoneal hemorrhage, it may lead to hypovolemic shock. If look, in the ruptured ectopic pregnancy, the tube has ruptured. When the tube has ruptured, there is massive intraperitoneal hemorrhage. If there is a massive intraperitoneal hemorrhage, it is leading to hypovolemic shock. How can we know that the patient here is in a state of hypovolemic shock? Her pulse is weak and thready, her BP is low or um, may not be recordable, her skin is pale, cold and calming, and the patient is swelling, and a slight elevation in temperature, usually about 101 or 2 Fahrenheit, may be found due to hemoperitoneum. Okay, and look, these are the scenarios. Please give them a look so that it may be further clear to you. A 25 years old primary gravida presented in emergency with 7 weeks of gestation, amenorrhea, mild PV bleeding. So the symptoms are here. She is pregnant and she has amenorrhea, gestational amenorrhea, and mild PV bleeding, and on examination she has lower abdomen pain. Lower abdomen is tender or abdominal pain is one and the same thing, and os is closed. So these are the triad is complete. It is a ruptured abdominal pregnancy. Then a scenario asked in 2016 which says that a woman is gravida 3. Gravida 3 means she is pregnant when only para is given, so she is not pregnant. But when gravida is given G3, gravida means a gravid uterus, gravida 3 a pregnant lady, para 2, so she already have true pregnancy, came to the OPD with amenorrhea. One symptom on transvaginal ultrasound, she has gestational sag 2.5 centimeter in right adnexa. Okay, note here, right adnexa and with no hemoperitoneum, and her beta HCG is 15,000 units per liter, I guess. Sorry, I forgot. So the diagnosis and medical treatment and the follow-up. So this is how the scenario is given. What do we see on abdominal examination? On abdominal examination, guarding and rigidity is seen in the presence of a ruptured tubal pregnancy. A ruptured tubal pregnancy is actually characterized by rigidity, the rebound tenderness, and which is a more pronounced on the affected side, and diminished or absent bowel sound. So you should remember that with the history of ectopic pregnancy and the ultrasound result of ectopic pregnancy and beta HCG level on abdominal examination, the patient has guarding rigidity, rebound tenderness, okay, then diminished or absent bowel sound. In case of massive intraperitoneal hemorrhage, two characteristic signs are seen, that is Cullen sign, which is bruising around the umbilicus, and great Turner signs, which is bruising on flanks. That is a very characteristic sign of intraperitoneal hemorrhage. Then on pelvic examination, on speculum examination, a small amount of dark blood may be seen in the vagina, and on bimanual examination, patient complains of severe pain on moving the cervix or the uterus, also known as chandelier sign, and affected adnexa is also tender. What is the outcome of tubal pregnancy? Well, the outcome, there are 5 to 6 outcomes of tubal pregnancy. The first is rupture. The tube rupture is the most common sequel of tubal pregnancy, which is responsible for its seriousness. Look, in the ectopic tube, the ectopic tube is not designed to carry a pregnancy, okay? So the more it stretches, the more is the chance of a rupture. So commonly the tubal pregnancy results in rupture, then tubal abortion. An implanted tubal pregnancy may get separated from the tube due to repeated chorioidal hemorrhages and expelled through the femoral end into the peritoneal cavity, where may can continue as secondary ovarian or abdominal pregnancy too. Then tubal mole, the separated tubal pregnancy, retained if re- if retained in the tube, may get surrounded by abdominal blood clots, and it is called tubal mole. Then abdominal pregnancy, the tubal ectopic pregnancy can continue as abdominal pregnancy when implantation extends into the peritoneal cavity at tubal rupture, and then there may be spontaneous regression. The tubal pregnancy may rarely regress spontaneously. Okay, that really happens. Then moving on to the investigations.